Good afternoon. Regarding the CA meeting, is that all of us have to mandatorily register to the National Council because the Government of India wants one registry for all the doctors throughout India. So it's mandatory whether you are registered as State Medical Council or not. And we going to the second session. The topic which is given for the second session is fear of death. The very moment we listen to this topic, it is just frightening to us. So, anyway, we are going to have an eminent speaker to allay our fear about the fear of death, a cardiothoracic surgeon, Dr. Kulasekaran. And he is a very eminent cardiothoracic surgeon. And right now, he is a senior cardiothoracic surgeon in Beyond Hospitals. He graduated MBBS from Chennai Medical College, both MS and MCH from Madras Medical College. He has a fellowship in adult cardiothoracic and transplant surgery in Greenland Cardiothoracic Surgical Unit, Auckland, New Zealand. And he has got a fellowship from the Greenland Center also. And he served in so many institutions. He is a junior consultant and senior consultant in Frontier Lifeline and the Dr. K.M. Cherian's Institute. And he is associate consultant in Apollo Hospitals, senior consultant from Kaveri Hospital to Trichy, and PG fellowship from Greenland Institute in Auckland and New Zealand. And now he is working as cardiothoracic surgeon senior person at MIA, as well as the Aspen Lower Hospital in Fiji Island. And he is very eminent in so many fields, not only the coronary artery surgery, the valvular heart surgery, disease of the aorta, surgery of the heart failure, and surgery for the pulmonary thromboembolism and so on. And he has award from Greenland Institute, I told you, and he right now is a member in IIMA as well as the Indian Association of Cardiothoracic Surgery, Pediatric Cardiothoracic Surgery, ECMO Society of India, and so on. And he is here with us for the next session, who is going to take us through the session Fear of Death. Thank you, Dr.
Good afternoon, everyone. Greetings from New York. First, I thank the respected Secretary, President, and members of IMPA for inviting us. And it's a pleasure to be among you this weekend and to share our experience. My presentation is about current concepts in management of aortic dissection. So, as it is a CME program, I have structured my presentation accordingly. You all know aortic wall has three layers: intima, media, and adventitia. And acute aortic syndrome is a group of pathology which involves all three layers. The penetrating aortic ulcer involves the intima layer. Aortic dissection tears through the medial layer, and intramural hematoma happens due to rupture of vas ovationis, mainly involving the adventitia. All these three pathologies are collectively responsible for majority of aorta-related mortality. Of these three, aortic dissection is the most lethal one. Over the years, the incidence of aortic dissection has remained stable. Every year, around 5,000 cases are reported worldwide. The most important thing about aortic dissection is once the tear happens, it's like a time bomb ticking, and the mortality is very, very high in the first 72 hours. It's equated to about 1% mortality per hour. So, aortic dissection occurs when there is a tear in the intima that allows the blood to pass through the tear and into the aortic media, and it splits the intima longitudinally, creating a flap that divides the true lumen from a newly formed false lumen. So the dissection flap can propagate both antegrade and retrograde. So aortic dissection has three components. The one is the intimal tear, second is a dissection membrane, and third is a false lumen. So the intimal tear most commonly occurs in the ascending aorta, just above the sinotubular junction, and less commonly in descending thoracic aorta, and aortic arch is the least involved. Aortic dissection can also happen without an intimal tear. The mechanism is the rupture of vasovasorum causing medial hemorrhage. The second component is the dissection membrane. As you have seen from the autopsy image, the dissection membrane is always thick walled because the dissection happens at inner 2/3 and outer 1/3 of the media. So always the adventitial or the outer layer is very thin. That is why it's more prone for rupture. The main complication of dissection membrane is it can involve the branch vessel and it can compromise blood flow. It can be either due to avulsion of the blood vessel or dynamic compression as a flap or due to intersusception of the membrane into the blood vessel. The third component is the false lumen. The false lumen is thin walled, as I said before, so it's at risk of rupture any time, and the false lumen is always larger than the true lumen. The most common cause is medial degeneration, which is due to cystic medial necrosis, and the second one is the connective tissue disorders due to defective synthesis of fibrillin protein. It's a glycoprotein that is important component of elastic tissue in medial layer of aorta. The patient at risk are mainly who have connective tissue disorders, of which the Marfan is the most common we come across. And next common pathology is patients who have bicuspid aortic valve. So the bicuspid aortic valve is part of the aortopathy, which not only involves the aortic valve but also the aortic root and ascending aorta. The next one is patients who have ascending aortic aneurysm. If the ascending aorta diameter is more than 4.5 millimeter, 4.5 centimeter in Marfan's, or 5 centimeter in patient with bicuspid aortic valve, or it is more than 5.5 centimeter in any patient, it is at risk of having aortic dissection. And third patients are patients who have a dilated aortic annulus. And these are also two unusual causes which can cause aortic dissection. First is the blunt chest injury. We all know that aorta has a mobile and a fixed structure. The ascending aorta and the arch is a mobile structure, but the descending thoracic aorta is a fixed structure. So at the junction between this mobile and the fixed structure, due to shear force, avulsion can happen. It can lead to aortic dissection to complete aortic transection. And the next common cause which used to see while I work in overseas is patient directly shifted from the gym with aortic dissection. So most of them try to do too much of stress, which can increase the intrathoracic pressure, which can lead to sudden rupture of the aorta. So this is one common cause of aortic dissection in otherwise very young, healthy adults. So there are two classifications, Stanford and DeBakey. Of this, Stanford classification is more clinically relevant. It's very simple classification. Type A, whenever the ascending aorta is involved or when you see a dissection flap in the ascending aorta, it's called type A. What it signifies is this patient is at risk of death anytime, so he needs an emergency surgery. Type B is whenever ascending aorta is free of dissection, they are at less risk of having sudden death, so they can be managed conservatively. So the clinical presentation, most of the patients died at the time of intimal tear. The most common cause is false lumen rupture or shearing of coronary arteries. Patient who survive sudden death can present later with hypovolemic shock, mainly due to exsanguination or sequestration of blood in the pleural cavity or pericardium or in retroperitoneal space. And the third presentation is organ dysfunction, mainly due to involvement of branch vessels. It could be a cerebral vessel causing stroke, or it could be a gut vessel causing visceral ischemia, or it could be a renal vessel causing acute kidney injury, or it could be a lower limb ischemia. Rarely, some patients remain stable and survive to progress to chronic state. So this is very important. So we have to differentiate between acute aortic dissection and acute myocardial infarction. It's sad to say that I have come across quite a few patients who have been wrongly diagnosed as acute MI and they have been thrombolized. Both these patients present with sudden onset of severe chest pain and ECG can show some ischemic changes. But thrombolizing these patients is a disaster and we cannot save these patients. But we have some clues. So patients with ST elevation rarely have aortic dissection. For some reason, aortic dissection related ischemia presents with ST depression and not ST elevation. So whenever you come across a patient who has some doubt of aortic dissection, please rule out before you thrombolize. So usually we can do it by a triple rule out CT or echo, cardiac enzymes and D-dimer. So the diagnosis is mainly by transthoracic echo and the CECT. Both of these can give enough information about acute aortic dissection. So what is the role of coronary angiogram in acute aortic dissection? So it's still controversial. It depends on condition of the patient and whether he has a pre-existing coronary artery disease or at risk for coronary artery disease and his renal function at the time of admission. So if facilities are available, our practice is to do a CT coronary angiogram at the time of CT aortogram. So now it can give enough information. So these points are needed for decision making. What we look from echo and the CT aortogram is whether there is a dissection flap or not. Presence of dissection flap confirms the diagnosis. And next is the intimal tear. Where is the intimal tear? And the number of tears, and is there any exit tear present? And what is the proximal and distal extent of the aortic dissection? And if the dissection has involved retrogradely, whether it has involved the aortic valve, if involved, how severe is the aortic regurgitation? And if the disease has further progressed proximally, has it caused any coronary artery avulsion? If yes, whether there is any infarction? And distally, is there any cerebral, renal, visceral or peripheral vascular malperfusion? So all this information has to be there before we make a clinical plan. So as far as indication for surgery is concerned, presence of flap in ascending aorta, that is type A, itself is an indication for surgery. Whenever we see a flap in echo or CT, that patient needs emergency surgery because untreated patients are at risk of either from false lumen rupture or due to coronary avulsion. And type B, surgery is indicated only if there is an organ malperfusion or if the aneurysm is at risk of rupture, like large size at the time of presentation or rapidly expanding aortic size. So if a patient is diagnosed to have aortic dissection, the first and most important thing is to have a strict blood pressure and heart rate control and also to reduce the force of contraction of the heart. So what we are trying to achieve is to prevent further progression of the aortic dissection and to avoid any tear or avulsion of major coronary or cerebral blood vessels. So what we aim is a heart rate between 60 to 80 and a systolic blood pressure less than or equal to 90 and a mean pressure less than 60. And we also have to monitor organ perfusion. So our drug of choice is esmolol because it is very short acting, easily titratable, and we usually give a loading dose of 500 milligram per kg or 2 to 4 minutes and then followed by an infusion to achieve the target. If patient is pain, adequate analgesics and sedation can further control the blood pressure. So the main principle of aortic dissection management is the operation is only palliative and not curative because it is not possible to repair or replace the entire aorta from origin to iliac bifurcation. So what we are trying to do is to save the patient life. So So the aim is to prevent death from cardiac tamponade or exsanguination by excising and repairing or replacing areas of actual or impending rupture, and to restore blood flow to branches of aorta that have been occluded by the dissection, and to correct aortic valve pathology. So we have three portions of the aorta. One is ascending aorta, second is arch, and third is descending thoracic aorta. The Stanford classification that way comes type A, type B, and arch is in between, intermediate. So type A dissection needs emergency surgery. The components of surgery is we resect the portion of aorta which has the intimal tear, repair the aortic valve or replace the root, and then replace the ascending aorta. And type B is usually medical management, strict blood pressure control alone is enough. In complicated cases only surgery is needed, which may be replacement of the aorta or fenestration of the dissection membrane or stenting of the occluded vessel, or sometimes if there is an avulsion, direct revascularization is required. Aortic arch is addressed only when there is an intimal tear in the aortic arch, or if the aortic arch size is larger at risk of rupture. The third and unusual complication of type B is retrograde extension to the arch, which I will briefly discuss. So as far as the evolution of aortic arch surgery is concerned, aortic arch is an anteroposterior structure. Ascending aorta is anterior, which can be accessed by midline sternotomy, and the descending thoracic aorta is a posterior structure which can be accessed through thoracotomy. But this arch is an anteroposterior structure, so it was always a challenge surgically to address the aortic arch. So for many years, aortic arch surgery carried very high mortality, and it was not practiced. So, but recently, Dr. Bose first started the procedure called the classic elephant trunk. These are one of the recent concepts coming up, where you do the front ascending aorta and part of the arch surgery through midline sternotomy. And what we call by elephant trunk is we push the graft through the aortic arch into the descending thoracic aorta, which hangs like an elephant trunk. That's why the name comes. And then as a second stage, patient can have a surgery or endovascular stenting through thoracotomy. And now recently, frozen elephant trunk grafts are available. So what is meant by frozen elephant trunk is, unlike the classic elephant trunk which uses Dacron graft, frozen elephant trunk uses stented graft. The main advantage is it has better approximation to the vessel wall, it's not collapsible, and it expands the true lumen better. So these frozen elephant trunk stent grafts are available for last 1 year in India. And further, with more and more intervention procedures coming in, we have moved towards now what's called a hybrid repair. Now there is no need to replace the entire arch. The surgery has been simplified. What we do is we repair the ascending aorta, and then we debranch the vessels. We disconnect it from the aorta, and then we stent the aorta. So it makes the surgery much more simpler and with less complications. So this is a procedure done by a multidisciplinary team, mainly surgeons and interventional radiologists work together. So I'll briefly discuss 3 case scenarios. So most of the surgeries we do for aortic dissection or type A dissections. I'll briefly run through the steps. So when a patient comes to us, they usually come with the CT scan which shows a dissection flap in the ascending aorta extending to a variable distance distally. So the first thing is to have adequate exposure of the aortic dissection. We usually cannulate the right axillary artery and right atrium, put the patient on heart-lung machine, we stop the heart, and second step is to clamp the aorta and then open the aneurysm segment. You can see very clearly the forceps holding the intimal tear. And third step is to resect the portion of aorta which has the intimal tear, which is mostly the entire portion of the ascending aorta. It is resected. And the next step is to repair the aortic valve, because the dissection passes through the layers of the aortic valve, the aortic commissures lose their support and they start hanging. So they become regurgitant, and patient has usually have acute aortic regurgitation. So what we do is we fix the aortic commissures back, and then we resuspend them, and then we put a glue through the layers, and we create a new media, and we make the aortic valve competent. And next is to use a Teflon foil reinforcement, so no further dissection happens, and then the ascending aorta is replaced with a Dacron graft. So this is the completed procedure. So what we have achieved is we have resected the intimal tear, we have replaced the portion of the aneurysmal aorta, and we have repaired the aortic valve. So all these prevents sudden death risk. Even though in this procedure we don't address the distal aorta, we are basically converting the type B aortic dissection to a type B aortic dissection. So type B aortic dissection runs a much stable course with strict blood pressure control. These patients may not require anything further other than constant surveillance. So next is the aortic arch dissection. So I'll run through procedures. So this is a patient operated a year ago in our center, 58-year-old male from Tanzania, who had a sudden onset of severe back pain of 3 weeks duration. He is only in hypertensive. This is X-ray showing mediastinal widening. Echo shows dissection flap seen in the aortic arch, normal sized aortic root, and trivial aortic regurgitation. And this is a CT aortogram picture of the patient, which shows the intimal tear in distal aortic arch, and it is proximally extend up to the aortic root and distally up to the left iliac artery. So the false lumen has involved the aortic root. Aortic ascending aorta is thrombosed with no flow, and the retrograde flow is seen in aortic arch and the innominate artery. So there is malperfusion related to innominate artery, left renal, and left iliac artery. This is a CT scan images showing the dissection flap and less perfused left kidney. This patient also had other associated anomalies like a single aortic origin of coronary artery, and he also had a common origin of left carotid and subclavian artery. And his cerebral angiogram showed an incomplete circle of Willis, which made the surgery further complicated, because for us to do an aortic arch surgery, a complete circle of Willis gives protection to the other hemisphere. When it is not complete, then we have to do additional cannulations to handle that. So the final diagnosis is a patient to have an aortic dissection, subacute presentation, type A, with intimal tear in aortic arch. So the treatment plan for this patient was first stage to do aortic dissection repair and the replacement of ascending aorta and debranching of the aortic arch with elephant trunk procedure, and followed by a second stage TAVR depending on how he is progressing. So the diagram shows how the procedure is planned. So this is an intro picture showing the aneurysm of ascending aorta and arch, the resected specimen, and that's the completed repair where the aortic ascending aorta and the arch is replaced, and there is a separate branch graft which goes to the innominate left subclavian and carotid, and there is another graft which has been pushed into the descending thoracic aorta, which hangs like an elephant trunk. So this is the classic elephant trunk operation. And what is surprising with this patient is when we followed up the patient, because of the elephant trunk, there is no flow through the upper descending thoracic aorta, false lumen. He started thrombosing and occluding much faster, and in 3 to 1 year follow-up, the false lumen has completely thrombosed and disappeared, and this patient did not require any further treatment. And this is the third scenario. This is a rare presentation where the uncomplicated type B dissection becomes complicated. It starts retrogradely progressing to involve the arch and descending aorta. So this is the CT aortogram. It shows a dissection flap involving the entire descending thoracic aorta and also extending retrogradely to the arch and up to the mid ascending aorta. So you can appreciate the dissection flap in the arch. This patient had a dissection, intimal tear, just distal to the left subclavian artery. So that's a CT coronary angiogram. It showed normal coronaries. This patient had a normal circle of Willis. So he had an aortic dissection. He presented late. It's a chronic and retrograde type A. So this patient, we plan to do a two-stage repair. The first stage of aortic dissection repair, followed by ascending aorta replacement and aortic arch debranching. So that's the completed procedure, which shows replaced ascending aorta with arch debranching. So this patient at presentation had a thrombosed false lumen. So we are managing conservatively. So in follow-up, if he shows any complications, then it can be managed with TAVR. Overall, the hospital mortality for aortic dissection is around 25%. The most common modes of death at early stage is stroke or organ malperfusion, mainly kidney failure, and late due to aortic rupture or pre-dissection of other areas of the aorta. The survival 1 year is around 66%, and 5 years is 54%, and 10 years is around 46%. So this patient needs a lifelong follow-up because the false lumen status we have to know whether it is static, thrombosed, or it is progressive to aneurysm. We also have to know the size of the aorta. If it's rapidly expanding, it needs attention. Whether the aortic valve repair is holding on any organ malperfusion is developing. So the protocol followed is the CT and the transthoracic echo before hospital discharge, and one after 3 months, and second one after 9 months, and then yearly thereafter. So acute aortic dissection is a life-threatening emergency. Though there are problems of late diagnosis and late reference, prompt surgical intervention is life-saving and gives satisfactory results. The current approach is conservative with aim to save a life. However, we have also moved towards preparing the base for future endovascular intervention. These patients are prone to develop long-term complications, and lifelong surveillance is required. Thank you.
So who are prone for aortic dissection?
Sorry, sir?
Who are prone?
Yeah, I have told you the few subgroups of patients. Patients with connective tissue disorders, especially Marfan's or Marfanoid patients, and patients who have bicuspid aortic valve. It's a part of aortopathy, so it's a disease involving the entire valve, aortic root and ascending aorta. Any patients with ascending aorta more than 5.5 centimeter, or patients with any aortic stenosis with more than 5 centimeter, they are at risk of aortic dissection. These are the groups which we see.
Is this also hereditary?
Which is unexplained. They have testicular
Is this hereditary or hereditary?
disorders or hereditary. They are part of the genetic syndrome. So a genetic counseling is needed for patients who have syndromes like the
Any investigation in order to detect this early?
Early genetic screening. So usually these patients we see one in the family will have, all others will have. So if there is a family history, there's a Marfanoid, we screen all their brothers, everything for this. Basically, we look at the size of aortic diameter. If it reaches the threshold, then we electively advise replacement.
On a routine, you can't do any investigation for a normal person. It's not necessary that everybody should have a genetic history.
No.
Routine, you can't.
It's a diaphragm graft. For dissection surgery, it's around 7 lakhs. The whole graft, everything. Yeah, so Mainly it's the blood pressure control, heart rate control. Because if the blood pressure is high, the remaining false lumen can expand and it can rupture. So we have to have a strict blood pressure control. There are no more questions on this particular topic. So at Maya we have world-class pediatric cardiothoracic unit. We do around 500 cases a year. Not IoT. Pediatric around all procedures come around 200 to 300. IoT is almost gone. It's a disease of
Indian boy, 10%.